All right, let's talk about appendicitis. It's one of those things, right? Super common, so you might think it's no big deal. But let me tell you, missing the signs can be, well, it can be a disaster. So whether you're cramming for an exam or you've been on the floor for years, this is one of those topics you've absolutely got to know inside and out.
So, to kick things off, I've got a question for you. Think about it for a second. What's the #1 reason someone ends up in the OR for an emergency belly surgery? Any guesses?
Yep, you got it. It's appendicitis. We're talking about the inflammation of that little finger-shaped organ, the appendix, that just kind of dangles off the large intestine. Sounds pretty straightforward, right? But, and this is a big but, if you don't catch it in time, things can get really serious, really fast.
Okay, so to really get a handle on appendicitis, we've got to start with the basics, anatomy. I mean, it's all about location, right? Knowing exactly where to look is, without a doubt, the most important first step to figuring out what's going on.
So picture the abdomen, okay? We split it up into 4 sections or quadrants. When we're hunting for appendicitis, our eyes are pretty much always locked on one spot, the right lower quadrant. You'll hear it called the RLQ. Think of it as ground zero, the epicenter of the whole problem.
All right, so we know where we're looking. Now, let's talk about what we're looking for. Honestly, diagnosing appendicitis is kind of like being a detective. You're collecting clues, putting the puzzle together. So what are those big, flashing red flags we need to watch out for?
Okay, here's the classic lineup. First up, you've usually got a low-grade fever. Then there's the nausea, maybe some vomiting, and almost always the person just has zero appetite. But the real telltale sign, the one you absolutely have to remember, is this weird migrating pain. It starts near the belly button, then it travels over to that right lower quadrant we just talked about. Oh, and rebound tenderness? That's a big one. It's when you press down and it hurts, but it hurts even more when you let go. Super classic. And a quick side note here, with kids or older adults, things can get tricky. Their symptoms might be really vague, maybe just some fussiness or discomfort, so you've got to be extra vigilant with that.
And you know, that pain usually lands in a super specific spot. It's called McBurney's point. It's right there between the right hip bone and the belly button. If a patient literally points to that spot and says it hurts right here, well, that's when all your internal alarm bells should be going off like crazy.
Okay, pop quiz time. This is a super common question you'd see on something like the NCLEX. So thinking about what we just covered, what is that typical journey of pain for someone with appendicitis?
And the answer is that classic migration. The pain kicks off around the belly button, the umbilicus, and then it makes its way over to that right lower quadrant. Seriously, if you walk away remembering just one thing about the pain, make it that journey. It's key.
Now there's a reason we're drilling this down. Spotting these signs quickly is everything, because with appendicitis, you are literally racing against a ticking clock. Putting off treatment isn't just risky, it can be, well, catastrophic.
And here's why. It's a simple, terrifying equation. An untreated, inflamed appendix perforates. It bursts. And perforation equals peritonitis. End of story. It's that direct, and it's that dangerous.
So what is peritonitis? It's a massive, system-wide infection inside your abdomen. See, when that appendix bursts, all this nasty stuff, bacteria, pus, leaks out into what's supposed to be a totally clean, sterile space. And just like that, you have a 5-alarm medical emergency on your hands.
So how can you tell things have gone from bad to worse? The signs just explode. That low-grade fever, it skyrockets. The heart starts racing. Breathing gets super fast. We call that tachycardia and tachypnea. And the belly, it becomes hard as a rock. They call it a board-like abdomen for a reason. This isn't just pain anymore. This is the body starting to shut down. It's shock.
Okay, that was pretty intense. We've laid out the problem. We know how dangerous it is. So let's flip the script and talk about the fix. How do we solve this and get the patient back on their feet?
All right, before they even get to the operating room, we have 3 immediate jobs. Number 1, NPO, nothing by mouth. They're going to need anesthesia, so we need an empty stomach. Number 2, get an IV going. We'll pump in fluids like normal saline to keep them stable. And number 3, pain meds. We'll get IV morphine ready to go, but there's a catch. And this is the really critical part. You absolutely do not give any pain medication until the surgeon has seen the patient and made their official diagnosis. Why not? Well, think about it. If you numb the pain, you're hiding the evidence. The surgeon needs to see exactly where and how much it hurts to be sure. Today, they'll usually confirm with a CT or an ultrasound, but masking those key symptoms can really muddy the waters.
The ultimate solution is a procedure called an appendectomy. It's pretty much what it says on the tin. They surgically take out the inflamed appendix. And once it's gone, the problem is solved. The source of all that trouble is just removed.
Okay, surgery's done. Now the game plan shifts to recovery. Our big goals are preventing other problems. We want to stop pneumonia, so we'll have them do deep breathing exercises. We get them up and walking early to prevent blood clots. We're constantly checking the incision site for any hint of infection. And of course, we give them the rules for home. No lifting anything heavy, and stick to showers, no baths to keep that wound nice and clean.
And last but not least, let's talk about the big do-nots. These are mission critical for keeping patients safe, and you'll definitely see them on exams. First, do not put a heating pad on the belly. It might feel good, but it actually increases blood flow and can make the appendix more likely to rupture. And second, absolutely no laxatives or enemas, ever. They increase pressure in the gut, which can literally cause the appendix to burst. Basically, we need to avoid anything that could pour gasoline on the fire.
So, that brings us to the big takeaway. We've seen how something that looks like a simple stomachache can actually be a ticking time bomb. So I'll leave you with this question. Knowing everything we've just covered, the next time a patient tells you their stomach hurts, how is that going to change the way you look at them? It really makes you think, right? A good, sharp assessment